Okay, so now we're going to talk about vital signs. And you'll notice in your vital signs PowerPoint, so again, that is posted in week 1. So make sure that you're following through with that as you're listening to this recording. And I'm also going to email you that PowerPoint as well for those of you who are listening to this before January 18th, and because I know you don't have access to Canvas, I think typically until the day before class. So as you're listening to this PowerPoint, make sure you have a copy of the actual PowerPoint out so that you can fill in some of the blanks and write notes as you need to. So let's go ahead and start. So today for this recording, just in terms of what we would typically cover at this point, in years past, we'll definitely get through heart rate and blood pressure. And then next, or the second week of class, we will discuss respirations, temperature, and pain before we talk about posture. So just to give you a heads up, the recording will only cover heart rate and blood pressure. So let me go ahead and share my screen. Okay, so vital signs, very important in any aspect of patient care that you are doing. Typically, when you think of vital signs, you probably think of more patients that are in a hospital situation, so either acute care or inpatient rehab. You tend to think about vitals more because the machine is there. You see nurses and not physicians don't typically take the vitals, but you'll see nurses taking vitals and other healthcare providers taking vitals. So it's more on the forefront of your mind. But don't forget, even if you are in an outpatient center or outpatient setting where your patients tend to be typically more healthy and maybe don't have as many medical issues going on, it is always, always, always a good idea to get a baseline set of vitals so that you know where the patient is starting, because you can't, just kind of like gait, you can't really assess abnormal gait if you don't know what normal gait is. And you really can't assess a patient's response to vitals. As a patient's vitals in response to exercise if you don't know what their baseline is. So just keep that in mind as you're out there doing patient care. Getting that normal set of vitals, or just that baseline set of vitals, even though you think it might take a little bit, the more you do it, the more practice you get, the quicker it's going to be. It's just a really good idea, and it's an excellent piece of objective data to have in your note. So why are vital signs so important? So it's definitely an indicator of our general health or physiological status. For all of the vitals that we talk about, there's definitely going to be the normal range that patients should fall under. So if our patients are falling below that normal range, it can indicate an issue. And then obviously if they're falling above the normal range, that can also indicate that a patient is having issues. And typically abnormal values may be indicative of just a general underlying illness, or maybe their body is just responding abnormally to the exercise or the treatments that we are providing for them. So it's always good to have that resting set of vitals, because I think sometimes we rely on their outward appearance. And I know I've definitely done this before, and we talked about this during our observation recorded lecture, that, what can we see or what can we tell of our patient just from their outside appearance. And sometimes, unfortunately, we can't see underlying issues going on based on their outside appearance. So for example, I was working with a younger patient. I believe he was around 25 years old, and he had been in a car accident and he had a head injury. And for the most part, from a physical standpoint, he was moving around quite well. We were definitely working with him more from the cognitive behavioral standpoint, more than we were from a physical standpoint. So I obviously was having him do a lot of high level physical work. And and trying to see if he could coordinate moving with other aspects of thinking and problem solving. And one thing that I noticed with him was when I would take his resting vitals, his resting heart rate was above normal. And so I believe it was falling like around 130, 135, 140. And so it was just really bothering me that his resting heart rate was so high. So I indicated that to our rehab doctor at the time. And she said, okay, she said, I'm going to go ahead and hold his therapy. She said, I want to check for a blood clot. And I said, a blood clot? I said, and I don't know if you guys have learned much about blood clots or DVTs, but the typical sign of a blood clot is swelling in the leg, redness in the leg, and obviously pain in the calf. And so I actually looked at his legs and I'm like, he doesn't really have any signs of a blood clot. And she said, I just have a feeling. I just want to, have him have a Doppler, which is a test that looks for blood clots. And I'll never forget, lo and behold, so he was obviously put on hold. And lo and behold, his test came back positive that he had a blood clot in his leg. And that was the only indication for him having a blood clot, was the fact that his heart rate was above normal. So, the physician just explained it to me that sometimes with younger patients, they may not always have the other symptoms that you typically see with a blood clot. And so I was pretty surprised and definitely learned my lesson that day. So, just one of those reasons why knowing our baseline vitals and knowing the normal ranges, why it is so important. So again, establishing baseline values. We also want to know, is the patient medically stable for treatment? So that example I just gave is a perfect example of that. Okay. Based on his resting heart rate, no, he was not medically stable for treatment. So obviously we didn't do treatment that day. We put him on hold, and then we had to do some investigation to figure out what was there. And then it also helps us find the patient's response to physical activity and exercise. So, especially it's important for the people that are listed here. So we're usually more concerned with how exercise is affecting a patient. If they're elderly, over 65, we have to be a little bit more careful. Any patients recovering from surgery, very young patients, those patients who are pretty sedentary. So having a patient that doesn't do a lot of movement even before they're coming to therapy probably aren't going to respond to therapy or be able to tolerate as much as somebody that walks 3 miles a day before they fell and broke their leg. So, and it can also, we also have to be careful with any of our patients who've had a previous cardiac issue. So generally, different factors that are going to increase or decrease vitals are going to be the level or amount of physical activity. Temperature can definitely impact vitals, a person's age, the emotional status of a patient, and then any physiological status of the person. So do they have an illness or a disease process going on? Are they on medications? So there's definitely going to be some medications, for example, that will automatically lower a heart rate. Even in response to exercise, that heart rate is going to basically stay at the same level. So it's not going to respond to exercise like you would think it was going to. And we're going to cover each vital a little more specifically in regards to what factors would either increase or decrease that particular vital. So how can vitals be used to establish goals for patients? So I'm just going to give you a couple minutes to think about, before we get into the vitals too much, how could we use vitals to establish goals for our patients or show that they're improving? So some examples I can give you, oxygen saturation. So we're going to learn about that in a little bit, but oxygen saturation is how much oxygen is in the patient's blood. We want that normal to be 95% or higher. And so sometimes that will be a goal that we set for a patient, is that they are able to maintain at least a 90% oxygen sat with exercise. Sometimes I will set a goal for a patient because based on their comorbidities or other pulmonary issues, sometimes it's not necessarily going to be realistic for them to not drop below that 95 or 90-ish percent. But sometimes my goal will be, okay, when they do drop, how long does it take them with proper breathing to bounce back up to the normal level? So if a patient is recovering, we call that, within, let's say, 30 seconds to a minute, that's better than them dropping below that 90% and it taking them 2 to 3 minutes of pursed-lip breathing for them to return to a normal level. So that's an example of how we can use vitals to show if a patient's improving or not. Another example would be a patient's heart rate while they're ambulating. So is their heart rate staying within normal limits based on the distance they're ambulating? So maybe it stays within normal limits after 60 feet of walking, but we notice that when they double that and they're walking 120 to 150 feet, all of a sudden they're no longer able to maintain their heart rate within normal limits. So again, that's just another example of how we can use vitals to establish goals for our patients. So let's first talk about heart rate or pulse. So as you guys, I'm sure, are very well aware that the heart rate is basically measuring the rate of contraction of the left ventricle, okay? And we measure heart rate in beats per minute. So the normal resting pulse rates for an infant is 100 to 130, child is 80 to 100, and then adult is 60 to 100. So for purposes of this class and the skill check that you will be doing for, measuring heart rate and blood pressure and respiration rate, we're only going to ask that you know the normal ranges for the adult. So when you do your skill check, you will be asked, what is the normal range for heart rate for adult? What is the normal range for respirations? And what is the normal rate for blood pressure? And so we're only going to expect you to know the adult heart rate. So the assessment of the pulse, you can do this with the use of the stethoscope and or palpation. In this class, we're only going to have you do it via palpation. In cardiopulm, I believe you will use the stethoscopes to actually auscultate, it's called, the different areas of the pulse. So different sites include the temporal area, the popliteal area, the carotid, which is in the neck, the brachial, which is in the arm, radial's in the arm, femoral's in the leg, and then the dorsal pedal's in the foot, and the posterior tibial is in the lower extremity, and then the apex of the heart, considered apical. So in your book, in the Fairchild book, figure 3-4 on page 55 has a great picture of all the different areas that you could potentially take a patient's pulse. A lot of times I will see nursing taking that dorsal pedal pulse when they're doing their assessment on the patient. But clinically, from our standpoint, probably the most common sites would be the radial and the carotid. So those are the sites we're going to pretty much focus on for this class when you are practicing taking the pulse on your lab partner. So when you're taking a patient's pulse, you are going to need a stopwatch or a clock or a timer with a second hand. So nowadays, no one wears watches anymore. Everybody wears or uses a iPhone, and that's what people use to tell time. Not that you can't use a phone or the timer on a phone, but I do think it's easier and better to use a watch with a second hand, just because it can be sometimes cumbersome to try to have your phone, get to the clock, make sure it starts, and then make sure it doesn't fade or the screen disappear before you're actually done counting the pulse. So just be very careful if you are going to try to do this with the timer on your phone. If you're going to rely on a clock, make sure that you're able to see it and there's no glare on the clock when you're doing it. So again, a watch with a second hand is probably the best option. When you're taking the pulse on your patient, the patient can be sitting, they can be recumbent or standing. You want to place 2 fingertips over the pulse site, and you typically want to avoid using your thumb. And does anybody have any idea why that would be? Give you a couple of minutes to think about why you wouldn't want to use your thumb to measure a patient's pulse. So for many of you probably know, we have a pulse in our thumb. So it can make it very difficult for you to try to figure out when you're assessing your patient's pulse, if you're feeling the pulse in your thumb or if you're actually feeling your patient's pulse. So that is why you want to use typically your index finger and your middle finger is what you're going to see people use to accurately assess the pulse. So if a patient is having a regular rhythm, okay, so as you're, feeling their pulse, everything seems to be regular. The beats seem to be at equal amounts in between. You can count the pulse for 15 seconds and then multiply that by 4. You could also do 30 seconds and multiply it by 2. Obviously, the longer you actually count the rhythm for, the more accurate your reading is going to be. If you have somebody that's irregular and their rate is kind of all over the place, then you definitely need to count for the entire 60 seconds. So the most accurate, and I think I've already answered that question for you, is going to be to count for that entire 60 seconds. Counting for 30 seconds, multiplying it by 2 would be more accurate than counting for 15 seconds and multiplying it by 4. So when you're assessing a pulse, you're going to be looking for different aspects of that pulse. So you're going to be looking for, is it strong and regular? So that their beats are even and you can feel it pretty easily. There's a pretty good force associated with the pulse. Or is it weak and regular? So the beats are pretty even, but you're having a really hard time trying to palpate it. It's just not as forceful as a strong pulse. Our lab assistant from last year, Maria, definitely had what would be considered a weak and regular pulse. It was very hard sometimes to palpate her pulse. Irregular would be both strong and weak beats occurring. So you would feel it normally, and then all of a sudden it would be like it would go away, or very hard to feel. And then maybe 3 beats would be strong again, and then 5 beats are very hard to feel. So that would be what an irregular heart or pulse would feel like. And then thready would be just weak and irregular beats. So the beats coming at a different pace. So abnormal heart rates would be anything, as far as a rate is concerned, is anything that is over 100 beats per minute, because remember that the range is between 60 and 100 for adults. So anything greater than 100 beats per minute is considered tachycardia. So tachy means fast, cardia means heart. So that's how you can try to remember that. And then anything below 60 beats per minute is going to be bradycardia. So brady means slow. Cardia again means heart. So that's going to be a slower heart rate, anything below 60 beats per minute. So factors affecting the pulse, again, go to table 3.2, page 54, because there's obviously a lot of different examples in your Fairchild book. I'm actually going to turn to that page right now just to make sure that I have that page number listed correctly. Yes, I do. Okay, good. So you're going to see in that chart, for example, with age, persons over 65 may exhibit a decreased pulse rate, where younger people usually exhibit an increased heart rate. Down to environmental temperature, pulse rate tends to increase with higher temperatures, decrease with lower temperatures. Physical conditioning, persons who are usually involved in frequent aerobic exercise, or someone who's really in shape and does a lot of training, will typically exhibit a lower pulse rate. Okay, so it might not necessarily be abnormal for them. It's just because they're pretty much in shape. So their heart is working very effectively. So you do need to know the factors that would increase or decrease a pulse rate. Okay, so make sure you're familiar with this table, 3.2, page 54. Okay. All right. So then abnormal responses to exercise, and I know this looks like a lot, but it's pretty self-explanatory if you read through it actually. And in the night, not the nice thing, but kind of a consistent thing is if you understand the abnormal pulse response to exercise, it's pretty much the same for blood pressure as well as respiration rate. So with your heart rate, you're going to expect it to slowly increase during exercise. Okay. I'm sorry. The normal response to exercise is you're gonna expect it to slowly increase as the rate of the exercise, or as the rate of the exercise increases, you would expect the heart rate to increase at the same intensity. Okay. If the pulse rate is raising slowly unrelated to the intensity of the exercise, that would be an abnormal response. So that sounded very confusing and I apologize. So let's review that again. So say for example, I'm on a treadmill and I am immediately going from 0 miles per hour to 50 miles per hour, or 50, oh my gosh, like 5 miles per hour. Then you would expect my heart rate to go up quickly. Okay. If my heart rate slowly increased, even though the intensity of my exercise was high, that would be an abnormal response to exercise. The pulse rate not increasing during exercise would be an abnormal response. If the pulse rate continues to increase or decrease as the intensity of the exercise plateaus, that would be an abnormal response. So you would expect the pulse rate to go up in relation to the exercise intensity. But if it continues to go up or starts dropping as the intensity of the exercise plateaus, that's abnormal. The pulse rate slowly decreases as the intensity of the exercise decreases, or the pulse rate doesn't decrease as the intensity decreases. Pulse rate decreases during exercise before the intensity of the exercise decreases. That would be a warning sign or a red flag. The increased pulse rate exceeds levels expected. So we're going to talk about max heart rate and what a target heart rate is. So if the pulse rate goes higher than that target heart rate, that would definitely be a red flag and an indication of wanting to stop any exercise. And then if the rhythm of the pulse, it becomes irregular at any time during or after exercise, that would be considered an abnormal response to exercise. All right, so let's just review before we go on to another slide. What is the normal range of heart rate for adults? Can you remember without looking back through your slides? What is the normal adult heart rate range? All right, that's 60 to 100 beats per minute. Okay. All right, so let's go on to the next slide. And we were just talking about max heart rate. So maximal heart rate is basically the highest heart rate that a person should ever achieve based on their age. Okay, and this would be that should achieve upon exertion in the absence of any cardiovascular pathology. Okay, so maximal heart rate is going to be 220 minus a person's age, and that would be their maximal heart rate. So I'm not going to use, well, let's go through this whole thing and then I'll give you an example. And then target heart rate is going to be the heart rate that a person should achieve during exercise for cardiovascular conditioning. So how do we know that we're working our patient hard enough, that we're giving them enough of an exercise program so that it's actually making a difference for them from a cardiovascular perspective? So that would be the target heart rate. So that's basically the range between 60 and 80% of their maximal heart rate. So this slide tends to give some people a little bit of fear because it does require us to math a little bit. I'll never forget, it's been about a couple of years now when we started talking about this, and one of the students was like, what? I have to math? I didn't think I was going to have to math as a physical therapist assistant. So there's very little mathing, I would say, in our field, but this is part of one of those times is when we are going to have to math. So I'm just going to give you an example. So let's try to apply these formulas for somebody that's 30 years old. So if there was somebody that was 30 years old, I'm going to give you a couple of minutes to figure out what their max heart rate would be. Hopefully I don't have to give you too long. Just as an FYI, you're not going to be able to use your calculator on a test that would have a question regarding max heart rate or target heart rate. You're not going to be able to use your calculator on the board exam for this. So you do need to be able to figure out, you would have a scratch piece of paper. Don't have to figure it out in your head, but you are going to have to know how to subtract, and you are going to have to know how to multiply 0.6 and 0.8 of a figure. Okay. So you figured out the max heart rate based on someone who's 30 years old. Now I want you to figure out the target heart rate for that person. So what would be the range of heart rate that we would want a patient to achieve? And that would indicate that, okay, yes, we are pushing this patient and we are challenging their cardiovascular system based on the exercise or the therapy that we're having them do. I'll give you a couple of minutes to try to figure that out. Okay, so if a patient is 30 years old, their max heart rate is going to be 220 minus 30. That would be 190. Okay, so then their target heart rate is going to be the low end or lowest target heart rate is going to be 0.6 of 190. So that would be 114. So that would be the lowest end of their target heart rate. The higher end of the target heart rate would be 0.8 times 190, and that would be 152. So if we wanted to see, if we were working with someone who's 30 years old and we were having them on the treadmill, for example, and we have them doing a certain rate per minute, and we measure their heart rate and we're getting 100, then we might not be pushing them hard enough. Okay. If we have them do a certain amount and we take their heart rate and it's 120, then we're going to say, okay, then we're challenging this patient. We're getting them within their target heart rate range. If we take their heart rate and it's 180, then what we may have this patient be doing, maybe it's too strenuous for the patient, or maybe that would then be a red flag for us that this patient is not responding well to that particular exercise, or maybe it is a red flag indicating that there's an underlying cardiovascular issue going on. So that is why it's so important to understand max heart rate as well as what the target heart rate would be for a patient. Okay, so hopefully that makes sense. And so I would challenge you to make up some other ages and try to do this strategy or do these formulas on your own. So another thing that we do with pulse is we grade the peripheral pulse. Okay. You're going to see different scores based on different sources. Okay. The source I'm using is the Score Builders book, because I know you guys had to purchase that. That's the book that you will be studying for your board exam. So that's the one I'm going to ask you guys to know. And so a 0 would mean that there was no pulse, that you are unable to palpate it. That would not be a good thing. A 1 means that there's a small or reduced pulsation. Okay. 2+ means that there was a normal or average pulsation. And then 3 plus would mean that there's a large and bounding pulsation. So meaning that it's very, very heavy or very easy to feel, I guess. It's almost like a pounding feeling that when you're taking the pulse. And I think we probably have all probably felt that on ourselves at times, maybe before competency, maybe before your final lab practical. I think you guys are probably all at that 3 plus range. So like I said, other sources will have different scales. But again, the scale is based on how easy it is, or the intensity of what you're feeling, not necessarily the rate, but the intensity of you being able to palpate the pulse. All right, so before we remove or go on to pulse oximetry, I'm just going to have you review what are the 2 most common sites of palpating the heart rate for a clinician. So what are going to be the 2 most common sites for you as a PTA that you're going to typically be asked to palpate a pulse? Can you remember without going back and looking at your notes? So the 2 most common sites are going to be the carotid and the radial. Okay. So let's talk a little bit about pulse oximetry or oxygen saturation. So the oxygen saturation or pulse oximetry measures the level of oxygen in the blood. It's a little device that you actually put on the patient's finger. It's actually going to give you a heart rate as well as the pulse oximetry. Typically, they will both be there available to you. Sometimes when you have patients who have poor circulation, especially our older population, unfortunately, that tend to have poor circulation, colder extremities, it can be sometimes hard to get a reading. Our patients who have nail polish can sometimes obstruct the reading. So you might sometimes have patients that have one finger that doesn't have finger polish on, and that's why, because it was impacting getting this pulse oximetry reading. So sometimes if the fingertips aren't easily or there isn't a good circulation there, sometimes you will see this taken on the earlobe. So the normal range for pulse oximetry or oxygen saturation is 95 to 100%. If you have a patient that's below 95 up to 90, it's not necessarily a red flag. It doesn't necessarily mean you have to stop therapy. It just means that they're not necessarily at that normal range, and we're always trying to get our patients to that 95 to 100. So anytime I have a patient that's falling like at that 92 to 90 range, I will typically instruct them in that pursed lip breathing. So pursed lip breathing is where we have our patients breathe in through their nose and then out through their mouth. So it's like smelling the roses. And so in through the nose with the mouth closed, and then out through the mouth. I think one of the biggest things or issues that we will have with our patients is our mouth breathers, okay? Especially those that are straining during exercise and holding their breath to try to complete an exercise. That can definitely cause them their pulse oximetry or their oxygen saturation to drop. And we know that if we don't have enough oxygen in our body, it's going to affect our brain, and it's going to affect how we're thinking and thought problem solving. And it's multifaceted when we start decreasing our oxygen level in our blood. So how we can help our patients improve their O2 sats is definitely by, like I just said, having them practice that pursed lip breathing, not having them hold their breath with activity, having them sit upright and really expanding their chest as they're taking breaths, not having that flexed posture, especially when they're ambulating, standing up. Again, we talked about in functional mobility, how patients are going to walk better when they're standing upright. It also allows them to breathe better. So anytime we do see a patient fall below 90, that's considered hypoxemia. So what do you think hypoxemia means? I think I've kind of already explained it, but if you break down that word, hypo means drop or decrease. Ox means oxygen. And then emia means blood. So knowing the roots of that word will help you remember what that actually means. So if you see hypoxemia and you're thinking, oh my gosh, what does that mean? Just try to break down the word. Hypo means decreased, ox means oxygen, emia means blood. All right, so let's go ahead and talk about blood pressure before we end this recording. So blood pressure, again, the reason to measure blood pressure is to measure the vascular resistance to blood flow. It measures the effectiveness of the cardiac muscle and the effectiveness of that muscle to be able to pump blood overcoming the vascular resistance. So how effective is our heart at pumping the blood through the body? So blood pressure measurement involves the report of two values. So I'm sure you have heard blood pressure readings being, when you get your blood pressure taken, the nurse will say, oh, you're 120 over 80 or you're 130 over 85. But you might not have ever really known what that was actually measuring. So the systolic pressure is going to be that top number, and that's the point of contraction of the heart muscle. So it's the measurement of the pressure exerted by the blood against the arterial walls when the left ventricle contracts. So systolic pressure is what is happening inside those vessels when the heart is contracting. Diastolic is what is happening inside those arteries when the heart is not contracting or when it's relaxing. So systolic is when the heart is contracting. The diastolic pressure, or that bottom number, is going to be when the heart is relaxing. So the blood pressure reading is going to be written typically as the systolic number over a diastolic number. So the equipment that you're going to need a stethoscope that allows you to listen to the artery, and we typically do this in the brachial area. And then a sphygmomanometer, and we do test you on being able to say that word clearly. Totally joking. We are not going to test you on being able to say that word because I'm actually shocked that I was able to say it so clearly the first time. Usually I don't. And I am going to show you a video later that allows you to practice blood pressures, and it cracks me up. It's a really good video because it's very detailed about how to measure blood pressure. So I really do like it, and it gives you a chance to practice. But the lady talks about how important it is to be able to pronounce that word. And I don't see it as being that important, but as long as you understand that is the part, basically the blood pressure cuff is going to be the sphygmomanometer. Twice in a row, I was able to say it. That's awesome. Okay. So the blood pressure cuff it does come in different sizes, and there will be an area that allows you to inflate basically the bladder, which is inside the cuff. And again, that's going to be what is wrapped around the patient's arm, very close to the brachial artery. So the blood pressure cuff corresponds to the arterial pressure. We kind of already talked about this, okay? Okay, so the method to prepare for blood pressure measurement, definitely want to make sure that you have the right size for your patient. They do come in various sizes. So there's definitely a pediatric size to adult to bariatric. So you want to make sure that you're using the correct size. If you try to use an adult size, a standard adult size on a patient who is larger, more than likely it's going to be either inaccurate or the blood pressure cuff is just going to basically burst off the patient as you're inflating it, which is never a very good experience. So you definitely want to make sure that you're using the right size. Then if you're using a normal adult size on someone that is small, again, it's not going to give you an accurate reading because you need to make sure that the blood pressure cuff can be put on the patient relatively snugly, okay? The nice thing about the blood pressure cuff is that there's going to be an arrow on the cuff that indicates where it should be lined up with the brachial artery, which is awesome. So you're going to wrap the cuff around the antecubital space. Again, you want it to be snugly wrapped around the arm so that you're not getting false readings. You do want to make sure that the upper extremity is supported and that the forearm are supported at the forearm so that the arm is at least level with the heart. Okay, so You can either do this yourself, you can support it with one of your arms, or you can position the patient's arm on pillows or maybe on a wedge or on a bolster, so that if you feel like you're struggling trying to figure out the blood pressure cuff and the stethoscope, then you could always support the arm on a different surface too. So when you're inflating the cuff, the standard rule is you always want to inflate the cuff 20 millimeters of mercury above the patient's normal systolic reading. And this will make more sense as we get to actually looking at what a cuff looks like. And I say 20 here. Sometimes you might even want to go 40 millimeters of mercury above the normal reading. So you always want to ask your patient, what is your normal blood pressure reading? You want to find out from your patient. Hopefully they know. Most patients know their normal blood pressure, because then when you're blowing up or inflating the cuff, you would want to start above their normal, because you're going to want to give yourself some time as the blood pressure cuff, as the gauge is coming down. You're going to want to give yourself some time to actually be able to listen before all of a sudden you start hearing the heartbeats. And so if you make it a rule of thumb to inflate it at least 20 millimeters of mercury above their normal, then it's going to indicate that you are for sure getting their true systolic number. So for example, if a patient's normal blood pressure is 153, but you only inflate the cuff, the dial to 120, you're going to miss their true top number, if that makes sense. So you definitely want to make sure you know they're normal and that you're inflating the cuff higher than their normal. And again, this will make more sense when we actually get to the training video and then do it in class too. So then once you inflate the cuff above their normal value, then you're going to slowly start deflating the cuff and observing the needle on the gauge. And you're going to start hearing different sounds, and you're going to start hearing the heartbeat. And that's what you're hearing. So the first sound that you hear is considered the first Korsakoff sound. That's going to be the systolic reading. That's going to be your top number. The last sound you hear is considered the fifth Korsakoff sound. That's going to be your diastolic reading. So if you go through this whole process and the blood pressure is not accurate, you don't want to take the blood pressure right away in that same arm. So what you can do is take it in the other arm, and then you can also wait 30 to 60 seconds and take it in the same arm that you felt it wasn't an accurate reading in. So you don't want to take it right away. You want to give the arm a minute to rest, restore to kind of normalcy, and then take it again. So again, those blood pressure sounds, they're called Korsakoff sounds. So the phase one or sound one is that first clear sound that you hear. That's going to indicate the systolic pressure. Then there's different phases. So phase two is you're still going to hear sounds. It's still going to sound like a heartbeat. It's going to be more muffled and swishing. Phase three, the sounds are going to become louder and clearer. Phase four is the sounds abruptly become muffled. Okay, so this is an indication of diastolic pressure. And then phase five, the sounds disappear. Okay, so for whatever reason, I just found an error on this. Based on these Korsakoff sounds, phase four or Korsakoff sound 4 is going to be the last sound you hear. That would be phase 4. I'm sorry, I don't know why that says fifth phase. And I didn't realize I had that in there, that inaccurately. So I'm going to, well, I can't change it right now because we're in presentation mode. But I will make sure that everyone understands that the last audible sound is the fourth sound. That's going to be your diastolic reading. The phase 5 is when there are no sounds at all. Okay, so the last sound you hear, that's going to be what you need to remember as the diastolic. Then you shouldn't hear anything after that. Okay, so again, systolic is going to be the first sound, first Korsakoff sound. Diastolic is going to be the fourth Korsakoff sound. And we do have this YouTube training video that I am going to watch a portion of that in just a minute after we cover a few more slides about blood pressure. So these are the normal readings according to your Score Builders book. Again, you're going to get different readings based on the source that you're going by or that you're reviewing. And so I'm trying as much as possible when I see different values from different sources, I'm trying to go with what's in Score Builders just because that is going to be what you're going to need to know for your boards. So I want you to be most familiar with that. So typically, we've always read that normal blood pressure is 120/80. Well, according to the Score Builders book, normal blood pressure for the adult is 119/79. Anything above 119 is actually not considered normal anymore. Anything below 79 is not necessarily considered normal. Infants, 60/90 over 30/55. Child, 90/110 over 50/70 would be considered the normal range. So again, this is based on the most current American Heart Association and American College of Cardiology guidelines. And again, this is in your Score Builders book. I wonder if I have a page. No, I don't. Okay. So normal blood pressure, again, is anything under 120 for diastolic. 120. And then for systolic, and then diastolic would be under 80. Okay. Elevated blood pressure is going to now that what's considered elevated, which this was news to me, I'll be honest. Elevated blood pressure is considered anything 120/129. And obviously there is no number for an elevated blood pressure. So there's different categories of blood pressure. Let me clarify this a little bit. There's normal categories. So normal blood pressure is anything 119/79. Elevated. So if you have a patient who has a systolic of 120/129, but their diastolic is still under 80, they are still considered to have elevated blood pressure. So the elevated category is only related to systolic. Okay. Stage 1 hypertension is you have your systolic is between 130 to 139. The diastolic is anywhere between 80 to 89. Stage 2 hypertension, so they get very specific, is at least 140 and then at least 190 for the diastolic. And then hypertensive crisis is considered anything greater than 180 for your systolic, and then anything greater to 120 is considered hypertensive crisis for the diastolic reading. So again, this is different for me, I'll be honest, because we've always considered normal blood pressure to be 120/80. But based on what's in your Score Builders book, we need to start thinking of normal blood pressure being 119/79, because anything above that now is not normal. So persons with hypertension are more susceptible to coronary artery disease, strokes, peripheral vascular disease, heart attacks, kidney failure, congestive heart failure. So hypertension is definitely something to not take lightly. One thing that you may hear being said is hypertension is considered a silent killer. So what do you think that means? Why do you think hypertension can be considered a silent killer? I'll give you a couple minutes to think about that. Okay, so basically, heart rate being or hypertension being considered a silent killer is because you can have increased blood pressure with absolutely no other symptoms. Okay, a lot of the patients that I will see that have had a stroke, I will ask them, were you on blood pressure meds? No, I had no idea that my blood pressure was that abnormal. I remember my mom telling me that she was 40 when she had to go on blood pressure meds. And the only reason she knew that she had high blood pressure was she went to the doctor for strep throat. She had a sore throat. They took her vitals like you normally do when you go to the doctor, and her blood pressure was through the roof. And she had no idea. No idea. So her doctor actually put her on blood pressure meds as young as 40. I remember once I was working with a patient, and again, outwardly, the patient was absolutely fine, chatting up a storm. I remember I was working with her in the bathroom. We were getting her ready for the day. She was all concerned about being able to do her hair and her makeup, which I totally, empower our patients to do that if that's going to make them feel better. And I absolutely always give them the time to do that, and I make it therapeutic. So we stand to do it, or definitely make it a little more challenging for them. And so I was just taking her baseline vitals, and everything looked great except her blood pressure was 205/95. Now, I'm not kidding. She was literally sitting in her chair having a normal conversation with me. And I said, wow. I said, are you dizzy at all? And she said, no, I feel absolutely fine. Her heart rate was okay. Her pulse oximetry was okay. And, the nice thing about being in the hospital, I'm not going to lie, is they have the blood pressure machines. So I was using a mechanical machine. Well, anytime I get a value that I don't necessarily think could be accurate, I will go and get a manual cuff. Okay. So I went and got a manual cuff, and it was still high. It was still very much the same. And so I went to the nurse and I just said, hey, I'm really concerned about this patient's blood pressure. And the nurse was like, oh, it's no big deal. She usually takes blood pressure meds, but we actually missed a dose. And so it's probably going to take a little bit before her blood pressure to come down. And so the nurse wasn't concerned at all, basically said, go ahead and keep treating her, doing what you're doing. She's fine. Of course, it's my license, and my red flag was up, and I wasn't comfortable still treating her. So I gave it about 5 minutes, took it manually again. It was still 200/95. So I just said to the nurse, I said, I'm just not comfortable with treating the patient. And so I didn't. And lo and behold, later on that morning, the patient was discharged to the medical floor because she was having signs of a stroke. So again, you have to be the one that makes the medical judgment of if you are going to treat a patient or not. Never make another healthcare provider talk you into it being okay. We definitely want to clear things with the nurses. We want to get their opinion. But just because a nurse says it's okay to treat a patient, if you, for whatever reason, don't feel comfortable, go with your gut, go with your instinct. Just make sure you're documenting why you don't feel comfortable treating the patient. Make sure you're communicating with your primary PT and the physician. And as long as you can justify why you didn't feel comfortable treating, that's what's going to be the important thing. Because ultimately it's your license. You're working way too hard to get this degree. You're going to work way too hard to get your license. You never want to risk that based on someone else telling you that it's okay to treat a patient. Hypotension is anytime your systolic pressure goes below 100 millimeters of mercury. So it's usually not a life-threatening issue. It can result in dizziness, especially when patients change position. It can also cause it can also cause tachycardia. Do you remember what tachycardia is? Tachy means increase. Cardia means heart. So it can cause increased heart rate. It can cause some mental confusion, restlessness. Your patient may become cool or clammy or pale because it could be a precursor to them actually passing out. So you do have to be careful when a patient exhibits some of these signs. One thing that you may see with a patient is they may have orthostatic hypotension, or you may also hear it called postural hypotension. So this is going to be a transient decrease in BP as a result of position changing. So anytime there's a decline in 20 millimeters of mercury or more for systolic and a decline of 10 millimeters of mercury or more in diastolic, that's going to indicate that the patient has hypotension. So sometimes you may be asked to measure or take the orthostatic hypotension. You might be asked to take orthostatics on a patient. So what that basically means is the physician wants you to take your patient's blood pressure with them laying down. Then he would want you to sit them up and have them wait for about 5 minutes, maybe 2 to 5 minutes actually. Take their blood pressure again to see if you're seeing that drop, that 20 millimeters of mercury drop in the systolic, 10 millimeters of mercury drop in the diastolic. Then you do it in standing. So it's basically taking the patient's blood pressure in a supine position, in a seated position after a little bit of rest, and then have them stand for about 2 minutes and take it again and see if it's consistently dropping with that change of positioning. And if it is, then they would be positive for postural hypotension. And so some treatments that you may see is ACE wrapping the lower extremities to help increase the pressure, help increase the blood pumping through the body. Sometimes you'll see like an abdominal binder or corset, elastic hose. Sometimes they're called TED hose. Very, very difficult to get on because they are so elastic. Sometimes just having our patients do ankle pumps, alternating heel to chest exercises can help reduce some of that postural hypotension. Sometimes, unfortunately, no matter what we do, it just a patient struggles with that, and it can be a real hindrance with therapy. And sometimes medicine can somewhat help, but I have had some patients that just really, really struggle with that. It seems like no matter what we do, for whatever reason, their blood pressure tends to decrease and drop, especially when they're up standing. All right, so just different factors affecting blood pressure. So again, this is from kind of a combination between the table in Fairchild. So your Fairchild text, table 3.6 on page 59. And then in your Cameron Monroe book on page 351, table 22.3 also had some different factors affecting blood pressure. So I basically just combined them all into one table for you. So again, factors that may increase blood pressure. So it might not, but it may. So be looking for that. And then factors that may decrease blood pressure. So I'm not going to spend time sitting here and reading these for you, but definitely be comfortable with knowing what could potentially increase blood pressure, what could potentially decrease blood pressure. So blood pressure response to physical activity, very similar to what we saw with heart rate. So the systolic should gradually increase with the exercise intensity increasing. It should plateau as the exercise intensity plateaus, and then it should gradually decline as the intensity declines. And then you should see a return to normal resting value within 3 to 5 minutes after the exercise ends. So again, very similar to what you saw with heart rate. And then abnormal responses to exercise, again, I'm not going to read these for you because, again, very similar to what the abnormal responses were for heart rate. Okay. So that's the end of the blood pressure section. So I'm going to go back to this video here. I hope this is not horribly long at this point because I do want to show this video. Again, I will have this available to you before class as well because I know you're not going to have access to Canvas. Okay, I want to make this bigger. There we go.
Welcome to this introduction to the skill of reading blood pressure. There are many parts to the skill of taking a blood pressure. This video is focused on learning to read the gauge. You will listen to several blood pressure.
So right now we are not going to listen to the whole video, just to let you know. We're going to listen to the part where they allow you to practice getting one blood pressure reading. And so we'll pause it there, have you guys try to figure that out, and I'll give you the answer to that. And then on your own time, you can use this as kind of a way to practice listening for and looking for the blood pressure numbers.
Readings. And you will then record your reading, so you will need some paper and a pen or pencil. The instrument used is called a sphygmomanometer. You will be able to say this word. It takes a bit of practice. A manometer is a device that measures pressure. Sphig, which rhymes with big, relates to blood. Broken into its parts, it is sphygmomanometer. The skill we are practicing is to coordinate what you hear with what you see on the gauge. You will listen for the first sound, which is the systolic blood pressure. Next, listen for when the sound stops. This is the diastolic blood pressure. Then write down your measurement. Every measurement has a unit that is part of recording the reading. For blood pressure, the unit of measurement is mmHg. This stands for millimeters of mercury. Hg is the chemical symbol for mercury. Even though mercury is rarely used in blood pressure devices today, this remains the traditional unit of measure. When recording the blood pressure measurement, write down two numbers as a fraction. The top number indicates the systolic blood pressure when the heart contracts with full force. The bottom number is the diastolic blood pressure when the heart rests and refills. Also, write down the unit mmHg. On a sphygmomanometer gauge, each mark or line stands for a unit of 2. There are no odd numbers on this gauge. No matter what you measure, you can only read what the units allow. Round up or down, but don't make up numbers that are not on the scale. These longer marks indicate units of 10. There is not space on the gauge to write all the numbers. Look at where 80 is marked and where 100 is marked. The long line in between indicates 90. You can see that the numbers 100, 120, 140 are written on the gauge. The unnumbered long lines indicate 110, 130, 150 between the marked numbers. The short lines all equal 2. Look at 100 and 120. The long line in between is 110, and the short lines equal 102, 104, 106, 108. The long line 110, short line 112, 114, 116, 118, long line 120. What do you think the number is just one line under 140? If your answer is 138, then you are correct. Now let's look at the markings as the needle goes down the gauge. Let's start at 150. What number is the needle pointing to now? It's indicating 138. Now the needle is pointing at 110. Where is the needle pointing now? It is indicating 68. Now for the moment you've been waiting for. These sounds are from a simulator arm and do not sound the same as a real person's blood pressure. But the idea is to listen for the sound and mark where you hear the first sound and the sound stopping. We will listen to 6 different blood pressures and pause between each to give you time to record your measurement. After all 6 blood pressures have played, the answers will be shown. Here we go.
Okay, I'm going to play that again and have you listen to it again. Right, not all the way there.
It is indicating 60 pressures.
If I don't want to make a video.
Okay, sorry. I was going to have you listen to that again. Why is it being foolish?
Hi, I'm Dr. Brian Paris, and I have an important question for anyone with arthritis. Which one of these foods contains...
Hey everyone, it's Sarah with Registered Nurse RN.
Well, I'm sorry. I was going to have you listen to that again before I gave you guys the answer, but I'm going to share this link for you guys so you will have access to this link here. So how many of you got 124 over 82? That would have been that first blood pressure reading was 124 over 82. So like I said, I'm going to share that link with you guys so that you can listen to the whole video and get the other, practice the other, I believe there's 6 total. Just so that you know, when we do the skill check, you will be required to be within 6 points of what your instructor hears or the proctor hears. So how we do that is we have a blood pressure cuff that allows me to hear what you're hearing at the same time. And so you need to make sure your systolic and diastolic is within 6 points. So we don't expect you to be exactly what we hear, but we expect it to be within 6 of systolic and 6 diastolic. For heart rate, you need to be within 4 beats per minute of what we're palpating. And then respiratory rate, you need to be within 2 respirations. So, but we'll talk more about that in lab. So I'm going to go ahead and stop the video now. I'm afraid it's probably way longer than I wanted it to. And then, like I said, we will pick up in week 2 with respiration and pain. And we will start working with this on the 19th.